بسم الله الرحمن الرحيم وبه نستعين والصلاة والسلام على أشرف المرسلين سيد الخلق أجمعين سيدنا وحبيبنا ونبينا محمد. We are going to continue the series lectures of approach to mammography. Today is the fifth lecture, continuing talking about mammographic views and optimizing diagnostic radiology, the second lecture. And okay, we are going to continue talking about mammographic views. Can you tell me what are these opaque structures in this mammography image? Any suggestion?
Nibble marker.
Okay, these are nipple markers. Or which one is nipple marker?
الاثنين
Where are the nipple?
inside the breasts.
These are the nipple markers. Okay. Yes. And what about this?
Clip. I think.
You mean breast tissue markers or skin markers? Last time we discussed, we differentiate between skin markers and breast tissue markers. Which type? So it is a markers. These are markers. Are not artifact, are not by chance coming here. But it can be sometimes they are doing like this, like the rings in the ear. Sometimes some people, they put something in their breast. Yeah, like in the nose and these organs, they might put it, but this is not the one. Okay, one suggestion, but it is not the one. These are skin markers, but which type of skin markers? Is it single skin markers or more than one skin markers? What is the shape of these skin markers?
Circle or triangle.
Yeah, so there are two.
Yes.
So I expect to ask me about the other view to see the exact location and now you can see it.
Two different.
Now are projecting over each other. These are skin markers projecting over each other. And now you can see the nipple in profile and the nipple here in profile, becoming profile, and the nipple markers outside the breast, but the other one is still inside the breast, is still the nipple, not out of profile. But what about these two types of markers? The triangle used for what and the ring used for what? Do you know?
I think the triangle for palpable breast lesion by the patient.
Excellent, well done. For the palpable abnormality, usually use is a triangle. Why it is triangle with a lucent center? When it is projecting inside the breast, so as not to obscure the associated calcification within the mass. You can see through it the calcification within a mass. And what about the ring usually used for what?
The skin mole or skin change.
Excellent, well done. This used for the skin mole. So here, this is a mole. Okay, you can see through the ring. And this is used for palpable abnormality. And here, this is the asymmetry representing the palpable abnormality. It's okay? Okay, so we went just through skin marker to revise what we have discussed last time. one of you can take this case and tell me what is going on. What is wrong, what is any abnormality, and what is how you can read this mammography.
Cranial view of left
So
breast.
okay, you are welcome, huh?
Cranial view of left breast, showing ACR1, ACRA.
One minute.
There is there is
Is it
irregular,
a single image or two
hyperdense.
image? One second. So here, you said cranial view of left breast. You have seen one or two image?
Two images of left breast.
You have seen two images. So you have to complete
Yes.
the definitions.
A small hyperdense.
Before talking about
irregular,
the abnormality, the
mass
labeling.
lesion. I think this is, yes.
You can see here
What?
one, and here two.
After 1 year, 2 years.
You have, before you start, you have to tell that.
Yes,
this
I want to
cranial-
comment on it. Yes, I want
Continue.
to comment. It increase in size, but I think this is mass because I have no midolateral oblique to see this is the asymmetry or no other view.
Go
But
from
this
the
is just a
beginning.
mass.
So go from the beginning.
Cranial view of left breast, ACR1.
Again, there are two images of cranial view of the left breast. One done after 1 year from the first one.
Yes.
This is a follow-up. There are two images, one a baseline and one after 1 year. You have to comment on that first. Do you agree?
Yes.
So from the beginning, I might not even with you. You are calling me and tell me by phone. You have to tell me you have two images for this patient, only craniocaudal views. One is a baseline and the other one after 1 year.
صراحة أنا كنت عايزة أعلق على الليجون، بعد كده أعلق على الكرينيكودا اللي اتعملت بعد السنة. كنت عايزة أعمل كده يعني أفصلهم ليجون
لا
وأفصل.
Okay, no problem. Okay, but you have to tell from the beginning you have two images. One, the difference between the two images is 1 year. You can tell like that. There are two craniocaudal view of the left breast with the difference between the two images 1 year. Then you can continue.
Okay. The first image showing irregular hyperdense mass lesion at the
طيب يا سهير.
Inner part
what
of
is the definition
of
of the mass?
breast.
Is it a mass?
For me, it is convex, has convex border here. There is a convex border here. So it looks like a mass. Looks a mass.
But sometimes, but when we have seen obesity in a single view, except for spot magnification view. If you have seen in a single standard view, you will call it
asymmetry in single view.
Until it fulfills the criteria of a mass. Yes.
There is a small area, a hyperdense small area at the inner medial part of the left breast, which increase in size after 1 year of follow-up 1 year.
Yes.
This lesion,
so we call it what?
Developing asymmetry.
There is asymmetry. هنا في first image we call it asymmetry. And in the second image we call it developing asymmetry. Why?
After 1 year, it increase in size and
because it becomes more conspicuous and larger and denser. More larger, denser, and more conspicuous. Okay. now it has some speculations and all this, yani, going toward a mass, but still I will call it, unless I'll see the MLO here, I will say this is a developing estimate, since I have a single view. Okay?
Okay.
What is wrong in this, yani? Do you have any comment in this mammography? Would you like to tell me something in the phone? Doctora, but I noticed I did not receive history, but I noticed something. What did you know?
The marker, there is a
There is
circle. There is a circle object in the medial, in the inner part of the medial part of the breast. I think it is a skin marker.
Okay, this is from outside. Why from outside? Because it's not present in the second image. Yeah, but
yes,
surrounding what? This circle.
Surrounding and calcification. I think it is calcification.
No. It was not seen in the original image. It was not seen in the original image.
موجودة في هنا الاثنين.
It is in the
original image. I said the original. So that means there is one image before this. This is what is available at the first one. But there is another, but there is previous mammography before this you have seen here.
Most likely there is either biopsy or something, because this is a tissue marker.
So you call it what? What is this?
Breast tissue marker.
Breast tissue, what is the shape of the breast tissue marker here? Which one?
I think the ribbon shape, but it is
this
not
one. This one. You see this tiny opaque structure. It looks like a bilobe or linear or whatever, or coiled or ribbon, or this is small object. This is a tissue marker. Here just they label it with a circle to show it for you. But this one, it is the same as this one. So there is a breast tissue marker. So what do you suspect? What do you learn from these two images? You have tissue markers, okay, since the earliest mammogram, and the lesion is progressing. So what does it indicate? What does it mean? Sarah Al-Mak, what do you learn from this mammography? What do you suspect if you have seen two images like this? What do you suspect?
I suspect
What do you expect this lady have? She had already
most likely
marker.
she had already intervention.
Breast tissue marker.
Okay. Yes.
What
most
do you
likely
think the previous result, the previous biopsy result?
Most likely it's a malignant, I think.
And the patient disappeared? You mean?
They receive treatment?
No. Here, this is screening mammogram. So this is a second round. Second round, I have to write here the second round of screening mammography. But if it is, if the patient on treatment, here it will not be screening mammogram. You have to look for the history.
Okay. If this is screening mammogram,
This is the second round.
Okay, in the second round, this is area of asymmetry. It is increasing in size.
Mm-hmm. Mm-hmm. Any suggestion for the previous biopsy? If it is this screening mammography, so if the biopsy result is malignant, so that it will be the second round, the patient, what is the patient management it will be? Here, if you are going to report this from the beginning, it will be BIRAT on screening. It will be BIRAT
0.
0. Then you will recall the patient for diagnostic workup. Yeah?
Yes.
You recall the patient for diagnostic workup.
Yes, definitely.
Okay. So after
Yes.
diagnostic workup, you did biopsy. And this is the tissue diagnosis. A tissue marker, I mean, breast tissue marker. And after this tissue marker, the patient went for screening mammogram or routine surveillance. So what does it mean? It means the result was benign. It means the result tends to be benign.
Maybe the result was.
Otherwise, if the result was malignant, she is not going for the routine surveillance, for routine screening mammogram. You know that, yeah? So you expect that the ultrasound guided core biopsy result was benign.
Okay.
What does it mean? What does it mean? What do you understand from all these findings? If you take it all together,
And
it
I
was
think maybe
guided biopsy.
The biopsy was in wrong place.
Excellent. Biopsy was in wrong place. So there was discordance, mammography ultrasound discordance. They have taken biopsy on ultrasound different from the site on mammography. That means mammographic ultrasound discordance. Okay, and this is the breast. Can you see it here? Far away from the site of the lesions where they had taken the biopsy. They had taken the biopsy from this area where the tissue marker is there. So it is obviously the tissue marker in a wrong place, is not at the same location of the real lesions. So, what do you suggest the next step in the management of this case?
So definitely, I will need the other views. I will complete the study. I need the other views. Okay.
Yeah. So diagnostic again, diagnostic workup.
Yes.
And
also ultrasound.
Aywa.
Okay. Second look ultrasound.
And
then definitely we need to rebiopsy.
Yes, we have to rebiopsy. If it was difficult, we'll go for
MRI.
Why MRI? The lesion is very clear here. This is a fatty breast. MRI, how is it going to help you in this case? For what? What is the indication of MRI in this case? It's not for MRI. Here you need to take enough tissue biopsy from the lesion itself, from the suspicious portion, breast tissue. So if it was difficult to take enough tissue as the lesion appear on ultrasound, you can place a wire and do excisional biopsy. We discussed the same things on the previous case in the group. Do you remember that? So we'll go for where localized surgical excision, and it revealed invasive mucinous carcinoma in that case. So what do you learn from this case? Or what did you learn from this case?
I think in the first
Yes.
okay, they already take a biopsy and they put tissue marker and they re-image by mammogram, but it was far from the lesion. And from the start, they have to go again and to re-biopsy the patient from the start.
From the start, we have to
be sure. Yes, they already image after biopsy.
We have to make sure the biopsy had been taken from
the right side.
Aywa. So the post-biopsy mammogram must be scrutinized for the location of the clip in relation to the biopsy site. We have to make sure the lesions from where they had taken on ultrasound is the same place as on mammography. And we should not consider the image-guided core biopsy completed unless we determine concordance, pathology, radiology concordance. Yani, if or before the pathology result came and the result concording the mammographic imaging, we cannot consider the biopsy procedure or the biopsy guidance, needle biopsy is completed. We have to make sure, and if there is any discordance, then we have to repeat the biopsy, including surgical excisions. This is the lessons from this case. So, breast tissue markers also, we went through it previously, and just to remind you by this case and its importance. And last time we discussed the mammographic views, and we said we have 4 standard view, CC for both breast and MLO for both breasts, as have been seen here. And you can see it here in the craniocaudal, the breast straight in the detector, placed here in the detector, and the X-ray coming from the cranial portion. And usually, as you know, we name by the direction of the X-ray. So craniocaudal, from above an X-ray coming down. And we talk about that. And the MLO, we said the image receptors placed along the axis of the pectoralis major muscles, and the X-ray coming from the medial portion of the breast, okay, perpendicular to the pectoralis muscle axis. And we said why we need 2 projections. Can you tell me one reason in this image why we need 2 projections? Or why do we need the 2 projections? 2 projections.
Because the breast is 3D organ.
Okay, excellent. So from this case, can you pick any reason for the need to have 2 projections? Can you Can you see something in one view you could not see it in the other view? Can you see this asymmetry?
Yes.
Can you see this asymmetry? Could you appreciate it here? No. The only thing here, subtle thickening of nipple areolar complex. That was a cancer. This is my case, and that was a cancer seen only on a CC view. That is why we mentioned before, quarter of cancer can be missed in a single view projections. And we discussed last time the importance of mediolateral oblique view and why it is oblique rather than straight lateral view, because the breast resting into the pectoralis muscles, and by putting the breast or by the placing the breast in that along the pectoralis major muscles, we can get the greatest amount of breast tissue in a single projection. So it offers a best opportunity to visualize the maximum amount of a breast tissue, okay? And visualizing the axillary tail, which is the part missed on the CC view, as well as the extreme posterior breast and upper outer quadrant. But the anterior, central, and medial breast are usually distorted on MLO, and especially the posterior medial breast. Usually, we said this portion most of the time will be out of the field of view of the MLO. And there are criteria to evaluate the MLO. As we mentioned before, it has to include axillary tail, inframammary fold, as well as the whole breast tissue with the nipple well aligned, adequate pectoralis muscle wide at the axilla, its apex below the posterior nipple line, and the submammary fold should be open and seen without artifact or folds. And when placed to MLO, it has to give the V shape form image. And also we went through the CC view, and we said the patient has to lean forward rather than going back so as not to miss the posterior tissue and superior and posterior tissue. And we said usually the technologist taking the breast by her hand like this, okay, to pull it forward to make sure the inferior and posterior breast is included and should be at the same level of the receptor image receptor, I mean, so as not to be high or low, leading to sagging of the breast and missing or drooping element, missing of some part of the breast. And also talking about criteria of evaluation standard CC view. What is this structures? What is this? What is this seen here on the CC view?
Pectoralis muscle.
Pectoralis muscles. So what does it indicate if you have seen the pectoralis muscle on the CC view?
Adequate breast, all breast tissues are imaged.
Yeah, so the breast tissue along the chest wall has no exclusion of any of breast tissue, posterior breast tissue along the chest wall. Generally, the criteria for the CC view are inconsistent. Why? Because only landmarks for consistent markers, anatomical markers for the CC view is the nipple. Okay, that is the only, is in the anterior part of the breast. We cannot take it as a marker to make sure complete inclusion of the breast tissue, but it can help. We need to see it well aligned in profile as well as central, pointing straight, not tilted, medial or lateral, at the center between medial breast. Okay, but pectoralis, visualization of pectoralis is not always achievable in the CC view. Yes, yeah, you can see in up to 60%. So we need to have other criteria to evaluate required to evaluate the CC view. If it is glandular tissue, we'll look for the retromammary fat. If it is fatty tissue, or I could not visualize the retromammary fat, then I will use the posterior nipple line. We'll go through in the next lecture, inshallah, in details. Don't worry, Sumaya. Okay, so standard view done, or views done. We said any view other than this CC or mediolateral oblique view, it will be an additional or supplementary views. Can you give me examples of this? Sumaya, do you remember any of the additional views?
Lateral, extended lateral.
Excellent, well done. Excellent.
lateral, medial, وفي modification أو spotlight.
Excellent. Excellent. Okay. Well done. Okay, so we have many additional views, but not all are commonly used, apart from the usually or most commonly used in the practice, the true lateral 90 degrees, spot compression and magnification views, extended lateral, tangential, rolled, and echelon or implant displace technique. So, to understand some of the importance of these additional views to diagnostic accuracy, we'll go through case examples. Who's going to take this case? No one? Huda, are you here?
Yeah. Assalamu alaikum.
Alaikum assalam wa rahma.
يا دوب دخلت أنا.
Did you attend the last time?
يا دوب دخلت أنا لكن I will try.
Okay.
This is the mammograph of one breast, CC view.
Which breast? You know, by direction, you can define right or left.
This is left breast. Yeah, left breast.
Left breast.
CC breast, CC view.
CC. Which one is CC view?
One.
CC
One
of left breast.
One is CC. Picture number 2, I think, برضو CC.
Excellent.
The third one is magnification view.
Excellent. Spot magnification.
Spot magnification showing microcalcification, which is not seen in the first image. I could see it only in the third. Microcalcification.
What is the difference between the three images? The third one, you said the spot magnification. Spot magnification, it means compression magnification view. Excellent. Demonstrate microcalcification. It's okay. Excellent. This 1 and 2, you said CC view. What is the difference between 1 and 2? What is this?
The implant.
Excellent. Well done. This is the implant. This is an implant. Which type of implant?
والله ما عندي فكرة والله.
ما عندك فكرة. It's okay. So here.
Which type implant? Saline implant.
Excellent. Why it
Saline.
is saline implant?
Saline implants, it's not dense, not much denser.
Yeah, the density, yeah, it is relatively less denser. You can see through it, and you can see something
You
here.
see
What is
hole. I think this is hole.
the port?
Port, yeah.
That is a port. So this is saline implant.
Okay.
طيب, what is difference between this image and this image?
In the first one, the implant is pushed posteriorly to visualize breast tissue.
Excellent, excellent, well done. And here the implant, it is in place. So this is in place, and this is displaced.
Displaced, okay.
Here, CC, an implant, they left the implants, it is usual place, as if it is in the, they just do CC, as if there is no implant in this image, number 2. And this one, we call it what? Implant displaced view. Implant displaced view. Okay. Or eclant view. And here, yani, if you look closely, you can see faint microcomplications. When they do it will be. So this is spot magnification, and this is implant displaced view. This is just a CC view. We call it a CC view.
Okay.
And here you can see the difference between the two. This is a CC view of a lady having an implant, and here this is the
okay.
And okay, would you please close your mic?
أنت انتبه كل بسرعة وخارجنا
رودينا would you please close your mic? She's not with us now. Her children. Okay, we said this is what? This is the breast between the image receptors and the compression bundles. Okay, and this is the implant. It is in its place, just taking the CC view. But here, while before compressions, they were pushing the implant posteriorly to visualize the breast tissue. In which type of implant we could see larger amount of tissue, abundant amount of tissue. We could see it when the implant, which type? Subglandular or subpectoral? Here it is seen well because, can you see the pectoralis? When it is subpectoral, it will be more easier. Can you see this example here? How it is, as if this image, as if it is the patient have no implant. You can see most of the breast tissue. It is well shown here because the implant is retro or subpectoral. Can you see it? In subpectoral. This subpectoral, but this one is subglandular. The pectoral is coming posterior to the implant. So implant displaced or eclant views done. What is this view? Still, we have a lot of views. All right, we have a lot of examples, I mean.
What magnification view?
It looks like, but can you think a little bit, yani, what could it be? I told you this is not exactly spot magnification. It likes spot magnification. It is something focalized view, but for certain region of the breast. Where? Demonstrate which part of the breast?
Medial part of the breast.
Deep or superficial?
Superficial.
Can you comment? Can you see what is this structure?
Is the skin here?
Can you see skin here and skin here? Here is more sharp. And what is this?
Nipple marker.
Yeah, this
Skin
is
marker.
skin marker. This is skin marker. This is a BB marker. So I could see the marker here along, as if I could see what? Can you see the marker end on, or you see on or in? You see it in which direction? On? Imagine that is a mole in the skin. Imagine this BB as a mole. So what is this view? And here you can see the mole sharply well defined like this. So you could see
Skin magnification view.
what?
Skin magnification view.
No.
I think of tangential view صراحة.
This is tangential view.
Okay.
That is tangential. Yani this is you can see along the surface of the skin. See? It is seen along the surface. That is the tangential view. This is the tangential, this is a BV, and that is the tangential view or tangent view. And what is this view?
Comparison, magnification.
Usually we are not using this numerical in spot magnification. And you can see something here. So think about it. Again, that is a tangential view. You see, alphanumeric grid, this is, they call it alphanumeric grid, and you can use BB and do tangential to make sure to look here in this case, in the first case, the patient having palpable abnormality. And here you are sure that the palpable abnormality is corresponding to the marker here. So that is the palpable abnormality, is an oil cyst or fat necrosis. By tangential view, you could localize exactly where the palpable abnormality. You see, that is the one without any overlapping, because tangentially, you can say that is the area where the palpable abnormality is by the BB markers. And here, sometimes you need to localize skin calcifications or a lesion in the skin to make sure is it within the skin or inside the breast. Okay, so what is the difference between these two images? This is zoom view, MLO and CC view. We discussed last time just to remind you about it. What about this calcification? Do you remember? Do you remember it? We said what? Do you remember? Any difference between this and this group of calcifications? Or look the same? Does it look the same or any difference between this group of calcifications?
Same.
Same. Excellent. Same. When you have a parenchymal lesions, parenchymal calcifications, what do you expect when you move the breast from one direction to the other directions? It has to be
Change the shape or the
It has
position.
to be changed. When it is fixed, that means it is within a fixed location. So where? What does it signify? At which location? And what is the sign? Last time we said the sign is, and what is the next step to confirm? You remember tattoo? We said this is a tattoo sign. This is a tattoo sign. Indicate that this is skin calcification. And you can confirm by tangential view. So we went through the tangential views. Let us go. What is this? What is this view? Part of a view. What is this? What are these opaque structures?
Calcification
why-
in the skin.
Skin only. Okay. Skin calcification. Where usually you are seeing skin calcification? In the breast. The common locations.
Medial or between two breasts.
And this is where? This is what? This is not between the two breasts?
Between the two breasts.
Yeah. So this is the angle between the two breasts. You see, this is one breast and this is the other breast. So this is, you said, Sumaya, go ahead.
Valley.
Yes, you are right. Why hesitant? Why you are hesitant? It is a valley or cleavage view. The valley between the breast. It is the valley between the breast or the cleavage view. Okay, let us go for another view. Still, just we are refreshing. Still, we have a lot to discuss. Let us go quickly here. What is this view? Okay, if you refer it to the standard view, is it similar to MLO or similar to CC?
CC, extending CC.
CC, which CC?
Extending CC.
It is extended CC, excellent. But extended lateral or extended
medially? Medially.
Excellent, well done. Because again, this is the valley here. This is the valley between the two breasts. This is the cleavage between the two breasts. So we went or we go more medially, and this is the medial extended CC view. Okay, and this suspicious calcification representing a DCIS. Because in the posterior breast, and we said that usually on MLO, this portion being missed. So, done. Who is going to take this case? To tell me which are these, what are these views? 1, 2, 3, 4. And what is going on? What is wrong? What is the abnormality? Volunteer. Any volunteers, I'll help you.
Okay. If no one, I will try.
You are welcome.
This is mammogram of the left breast.
Excellent.
The first image MLO.
One,
The second
MLO, excellent.
MLO, CC.
CC, excellent.
3
Is it
and 4
adequate, CC? Is it adequate, CC?
not adequate because the
Why?
inner portion not well seen, and the nipple is not in the center of the image.
Excellent. The nipple is tilted laterally.
Laterally
And they pull medial more in
than
expense of
lateral.
the lateral portions. It's okay. So, and I could not evaluate well for the posterior breast. Okay.
Okay.
So this is a CC view. Excellent. So what do you expect this one will be?
This is a spot magnification view.
Is spot, excellent. Compression magnification view of
Compression.
أيوة
Of the
ما هي
MLO.
spot is the same.
Mm.
Just I remind you. Is spot compression, I told you last time.
Mm.
All alternative names for the same view. Spot compression, compression mammogram, focal compression, all these are alternative names for the same view. So it is, but when we said spot magnification, that means combination of magnification along with compression. Okay. So spot magnification, excellent. Huh? So,
the 4 one.
But perform in which view? Usually spot magnification should be either يعني from other view. MLO magnification. You can see the pictorial here.
Yeah.
This is from this one. They have done MLO. Okay, MLO is spot magnification. Because the lesion is seen on MLO, they make spot magnification. Huh? What is the result of the spot magnification view? Or compression view?
It's better visualizing the asymmetrical area seen in MLO and not seen in CC view.
No. Your result of this case. So how you are going to read this spot?
Focal asymmetry, dense area.
If you have seen a focal asymmetry, what is the next step? You have to do it.
The spot compression, the spot magnification.
Why? No, spot compression. But why?
To make sure, is it asymmetry, real symmetry, asymmetry, or it's just a granular tissue?
Excellent, well done. So, according to the finding, you will decide, is it a true lesion or a pseudo lesion? So, you have to tell now, is it a real lesion or a pseudo lesion? And based on what? This is my question.
I think it's a lesion.
You think, or you sure it is a lesion? Are you sure is it a lesion, or you think it is a lesion?
I think it's a lesion. I think it's a lesion.
You think it is? يعني still you mean that do you mean the spot magnification doesn't help you? Still you are in doubt. Is it a true lesion or a pseudo lesion? Do you agree?
Yeah.
Okay. So it doesn't help you much. This is what you mean. Okay. Let us go further. What about the other number 4?
Number 4, this is the spot magnification for the CC view.
But that is the CC view here. Can you see anything in the CC view?
I couldn't see the posterior portion in the CC because it's inadequate.
So definitely this is not the CC, because this is your CC. And here they are, at least they are pointing or something, and you can see So, where you have seen the pectoralis muscle? In which
the
part?
fourth.
At the center?
لا superiorly.
So what does it mean when you see appearance like this? You can see the pectoralis here. Look for the image.
So this is
At the beginning, you said this is a CC view, and you can see you could
CC.
see the pectoralis more
more clear laterally, so it's extended lateral view.
So this is the thing, how this is the way how you have to think. This is it looks same like the CC view, but I could see the pectoralis more laterally. So I went extended lateral view. That is why I could appreciate something posterior here. Type. What do you think now?
It's a real region.
Why?
Region.
Why?
It is seen in two view.
Seen in two views. Excellent. Type. Let us go back for the spot magnification. When you will say on a spot magnification, this is a pseudo lesion, and when you have to say this is a true lesion or a real lesion. Do you know?
If it's seen in a spot view, I will say it's a lesion, a true lesion. If it's not seen, I will consider it as glandular tissue.
So, do you have seen it here or not? It persists and with more clarity. Here it persists. Did you see this arrow? That is the area of asymmetry. It persists and become more obvious than the remain of the breast tissue. Look for the remain of the breast tissue, it fade away. While the lesion, it become more obvious, more clear, more dense. That means this is a real lesion. This is a benefit of the spot magnification view. And the benefit of this spot, this is again spot view, but of extended lateral view, you see, because I understand since the lesion is seen here at the parenchymal apex, that means for the axillary tail. And clearly here, the medial breast is well pulled in expense of the lateral breast. So from this image, I expect that this lesion, it will be on the lateral breast. That is why they went to extended lateral view and demonstrate this suspicious. Here you can see speculated high density mass, okay? And it was invasive cancer, I think. Let us see, this is spot compression, spot lateral exaggerated CC, and it was invasive, small invasive cancer, okay?
Okay.
Next. Rutaina, do you like to share? Rutaina, do you like to take this case? You are not with us, or okay. Fatma Bakhit.
Yes.
You can take it.
Okay. This is a single MLO.
This is MLO. Demonstrate. It is written here. Single MLO asymmetry. That means what I have seen here is seen only on MLO. Seen only on MLO. So what is next? What is next step in the management? If you have seen a case like this, how you are going to manage the case?
Exaggerated extended lateral view.
Excellent. Why? Why you select this view? Why do
the lesion it's adjacent or anterior to the pectoralis and
Yeah.
the outer.
It's posterior. It's so posterior lesions, but very unlikely to see this so posterior lesion in the medial portion. At superior posterior, most likely, it will be on the lateral breast. And there is one clue here, that MLO even is not an optimum. Can you tell me why it is not optimum MLO?
Nipple is not in profile. Pectoralis muscle is not the inferior end of it not seen.
Excellent. 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 Deficient pectoralis muscle. You can tell very deficient pectoralis, and here it is contracted, and you see it is contracted. So most of the posterior breast might not be included in this image. So I'll go for the extended lateral view. Okay. So
معلش
this.
يا دكتورة رباب.
أيوة.
ممكن تعيدي بس حتة ليه اخترنا الاكستندد لاترال فيو تاني بس الحتة دي.
Extended, usually we are not selecting directly like this. We have a rule to, if you have seen a lesion on CC view, to select which, or we have seen a lesion on MLO to select which. But اللهم صل وسلم بارك على سيدنا محمد. In this case, when I saw asymmetry in extreme posterior superior MLO, extreme superior posterior MLO, very unlikely to be in the medial breast, because as we mentioned before, this is the, think about yourself, شافانا الله وعافانا جميعا وحمانا. If you have fibroadenoma, okay, in your extreme superior medial breast, and you have done MLO, most of the time it will be outside the field. Do you imagine it? This is a superficial part, shallow portion of the breast, medial, upper medial. This shallow portion usually, okay, when you make a compression, it will be outside the field of view on the MLO. So this is the area usually deficient on MLO. I don't expect, when I have seen a lesion in superior posterior MLO, to be from the medial breast. Very unlikely. Most of the time, it will be from the lateral breast. I can go directly for the extended lateral view, and mostly you will see it. You got it?
Yes, thank you so much.
That is here. That is the extended
lateral.
Yes. ها؟
سؤال معلش، يعني انا قبل ما انا اعمل طوال الاكستندد فيو قبل ما اعمل الكومبريشن، ولا الخطوات، يعني ترتيب الخطوات لما انا القى فوق الاسيمتري؟
No, it depends. يعني ما here in the previous one you are in doubt, is it real or not? But here mostly it will be real. But at the end you can do spot, and in the same setting go for extended lateral, or you can do the extended lateral, and if you did not see it, but still it can be technical. But yes, you have to do spot first and go for the extended lateral view.
Okay.
But this one mostly is a real lesions from its shape and this appearance and effect and associated features. It goes with more real lesion. When it gives impression that this is the real lesion, I'm not doing the spot just to make sure is it a true or true lesion or pseudo lesion. I'll go just to localize it, and then I'll go for ultrasound just to reduce the mammographic images. But
Okay.
if I need it, I'll do. Because whenever I do one view, I have to to defend myself why I have done that view. Otherwise, this is additional radiation.
Unnecessary investigation.
Yeah, unnecessary radiation.
Hmm.
We have to define ourselves. So this is also invasive cancer. The CC view was not seen, and the lesion was not seen on the CC view, seen only on MLO. On extended lateral here, it is clear it is a mass with a convex border and speculated margins. They went for ultrasound and ultrasound guided guidance biopsy revealed invasive ductal carcinoma. Huh. Who is going to take this one? نورس.
ايوه بس معلش هيجيلك سؤال.
Now my I expect to be familiar, you to be familiar with this. سؤال؟ Who said
معلش
he
يا ابو
has?
سعيد قلت شنو معلش بس دول دق لي الباب معلش.
No problem. I said, can you check this case?
Yes.
Yes.
طيب this is a mammogram of the left breast. The first image is MLO.
Excellent.
And the second one is CC view.
Excellent. Well done.
طيب the first one shows asymmetry at the deep
Excellent.
deep lateral.
Why you said lateral?
Because of what we just said قبل شوية when I asked the question.
No, but you cannot say confidently.
That's why. Confidently. That's why.
Here you will. Let me tell you. Let me explain for you. Let me just explain for you, my dear. On MLO, just you will divide the breast from the nipple by posterior nipple line. Above that line is superior, and below that line is inferior.
Okay, so it's superior.
Along or central. So you can say, you can imagine that the nipple, it is just above the nipple. It is extreme posterior, okay, central to upper. That I will describe it like that.
Say again يا boss معلش صوتك بيقطع. Central to what?
Central to slightly upper, because it is just superior to the posterior nipple line.
Yes.
You see? So in the upper half, the lower portion of the upper half.
Okay.
Okay. An extreme posterior prepectoral region.
Okay.
It is seen only on MLO.
MLO.
Is it appreciated on CC?
See it, or actually,
can you see it on the CC view?
I might be seeing a very little part of it, but I cannot commit myself, so I'll ask for.
Are you talking? No, Nauras?
Talk. Hello?
صوتك ماشي بعيد. بقينا ما سامعينك.
دخل تلفون معلش. قلت لك يا بوس انه انا في السي
ما سامعينك. We could not hear you.
سامعيني؟
No.
صوت بعيد.
دقيقة لحظة بس معلش.
دكتورة رباب بس يعني أنا خدت فاتحين المايكات يقفلوا ما عدا يعني أنت ونورس بيحسن الصوت يعني بس اللي عايز يتكلم يفتح المايك.
Yes. It is a good suggestion.
سامعني؟
Now yes.
طيب معلش بس دخلت مكالمة وبتفصل الصوت مني. قلت لك انه في السي سي فيو I cannot appreciate
excellent. Would not be appreciated. So we are dealing with
a case of uncertainty for me. So I would ask for another view.
single, we call it single view asymmetry. A single view lesion or asymmetry. Yani when we say asymmetry, that means opacity seen in a single view. This is just, we call it asymmetry. Or you can say a single view lesion, suspected lesion, or a single view lesion for workup, for further workup. Okay? What do you like to do further?
I would like to request another view.
Which view you are going to select?
Extended lateral view.
Excellent. Why extended lateral?
To localize the
why you select the extended lateral? Now here you can answer.
Yes, because of the position of the first focal asymmetry being in the superior portion, I would like to confirm it being in the lateral or medial. It is unlikely to be seen in the medial, but it appears.
If you do, can I explain to you this point, my dear? When you do extended lateral CC or exaggerated lateral CC, that means you expect the lesion to be on the lateral view.
Yes.
Okay? Not, yani, your explanation, not to see if the lesion is lateral or medial. You will tell me because
myself, you mean, صح?
Because the lesion is so posterior, upper breast, upper, usually the posterior upper on MLO expected to be in the lateral breast.
Yes. Okay.
That is why I'll go for the
extended lateral
view. So let me show you the extended lateral view. Is it extended lateral view or not? Or a CC view? What do you think?
It's a CC view.
It is a CC view. It is not extended lateral. It is not exaggerated CC view.
So
that's why I asked you.
It's a CC view.
It is written here a CC view, but this is exaggerated lateral CC view. Why? We explained in the previous case. It seemed the appearance same like the CC view, but look for the nipple, and divide the posterior nipple line here.
Yes.
Look the medial portion to the lateral portion, relative to the lateral portion. Which one is large? The lateral. And look for the pectoralis. Is it central here? If it is just a CC and you want to, you might see the pectoralis, you will see central.
Yes.
Again, is the nipple.
Yes.
But now you can see the pectoralis here more lateral, as if you are doing MLO.
MLO, yes.
When as if I'm saying as it looks like. It looks
I know.
like. Because when you do the CC view, you will take, as we explained last time, you will go more lateral and you will take forwarded. You will forward the lateral portion more pulling. That is why the pectoralis here it appear. So when you see the pectoralis, that means inclusion criteria is optimum. You could see till the end of the posterior breast is included. That is why with this view, you could appreciate and you could see the posterior.
Okay.
Okay? So
yes, okay.
This is not a CC view. This is extended lateral CC view or exaggerated CC view. You got it?
Yes, I did.
What is this image? Do you know it? It looks
no, not actually.
باب معلش ممكن ترجعي للسلايد اللي قبل اللي فاتت دي القبلية. ما دي بتاع القبلية. أيوة هنا أيوة نفس دي الكيس دي. لا ما دي بعدها دي اللي بعدها.
This one.
أيوة الكيس دي. ده ميديولاترال أوبليك وقلت اكستندد لاترال. هنا ده أعرفها كيف اكستندد لاترال من CC في الفيو ده هنا.
Why? Because I told you here, this is a single MLO asymmetry. So not seen, the CC view not shown. But I have given you the information. I told you this is a single MLO asymmetry. What is the next I have to do? What is the next? The next it will be, because it is superior posterior, extreme posterior superior, this portion very unlikely to be in the medial breast. No need to do lateral to make sure, make all this triangulation. We are going to do the triangulation. But when the lesion in the upper, in the extreme superior posterior, I expect to be lateral. I'll go directly for the extended lateral. Okay? That is why I told you from the experience you will learn. Just a minute, from the experience you will learn, yani, each different case, the management of each different case is unique. You cannot follow the same rule for all the cases. And from your practice, you will learn to minimize the radiation for the patient. We don't like to do many views. Just try to select which view can help you in the workup of this case. And since I have seen it here, I'm not expecting that it will be in the medial breast. Why not to do lateral to make sure if it is goes up or goes down to suggest it is lateral or it is medial. I'll go directly to the extended lateral. So I told you this is an extended lateral view. And if I told you this is a CC view, is it an optimum CC view? No.
No.
This is a nipple. This is a nipple. This is a posterior nipple line. Compare the medial portion in relation to the lateral portion. Almost double. The lateral, included lateral here, is almost double distance of the medial. And you can see here even the fault or the axillary fault. Can you see?
Yes.
This is extended lateral view.
Okay.
Okay. So what is this, Suhair? What is this image?
This is
Suhair.
MRI.
So what does it add? Does it help in this case?
No. Same as mammogram.
It confirmed. It confirmed this. It confirmed. Here I can see, okay, a focal asymmetry. Now I'll call this is possible mass focal asymmetry with possible mass, because I could see it in two views with some convexity here. So it might be a mass. So the MRI confirms that this is enhancing with associated non-mass segmental enhancement, so are suspicious, and under ultrasound guidance biopsy, it was infiltrating ductal carcinoma. Take this one. Now you have to tell me, Yasu, here, which view each of these image. 1, 2, 3, and 4. This is straightforward. This number 4 is
CC view.
CC view. This is clear. And number 1?
Mediolateral oblique, but not optimum.
Excellent. Well done. This is MLO, not optimal. Excellent. So what could you see here in the mediolateral oblique?
An area of focal asymmetry at the posterior.
Suspicious asymmetry in the extreme or toward the axillary tail.
Superior Yes, towards the
axillary
axillary.
tail. What do you expect this view to be? It looks like which one? Looks like CC or looks like MLO?
I think this is mediolateral.
Yes, this is straight lateral. Here you can see here the inframammary fold, and you see the nipple in the location of the nipple here, and the appearance, even the orientation of the parenchyma, more similar to the MLO. So this is straight lateral view.
Okay.
So what do you expect this view to be?
This is extended lateral.
Excellent. Why?
Because the more conspicuous lesion seen in the posterior superior.
Yeah, this is obviously here in the axillary tail. So, and even they have done the lateral view.
Seen.
It was not shown. Extreme posterior. But with extended lateral view, you could visualize that. So you are right. This is CC mediolateral, the other oblique, exaggerated craniocaudal view. And this one, Sumaya, that is for you. Tell me just which view. Each here it is, yani, so it is obvious. Sumaya, are you with me? What is this view?
Mediolateral.
Mediolateral oblique. Mediolateral or mediolateral oblique?
Lateral oblique.
Oh, yeah, complete mediolateral oblique view. Excellent. Demonstrate.
Demonstrate suspicious
speculated high density mass. Forward. This is speculated high density mass here. It's okay. Why I said speculated high density mass? This view is
what? Where is it, bro?
This in the middle.
In the middle. This is CCU, but not complete CCU. Because
this is CCU, not CCU. But CC. You imagine you are in the hospital.
Yes.
Okay, the CC view. Okay. Yeah, because I could see part of the lesion here in the CC view. Okay, that is why I said this is speculated mass, because I could visualize it here. But it is not so clearly seen. So from here, I could see part of the lesions. Where? In which part?
In the CC view, we see part of the lesion. In mediolateral oblique, we see the lesion clear. Then we do extended lateral.
Why I go for the extended lateral view? Why? On what base? Why I select the extended lateral view?
Because in the CCU, the lesion was more posterior.
It can be posterior medial, because it is lateral. Because here the lesion, it is obviously at the apex of the parenchyma, and most likely here I can say it is most likely on the lateral view. But from the CC, I am confident that the lesion, yes, is lateral. It is posterior lateral. I could not see it well because it is at the posterior end of the parenchyma. So I will go for the extended lateral, because in the extended lateral, I will go more toward the lateral, pulling the whole breast laterally. I ignore the medial portions. So I will pull till the end of the posterior lateral breast. I just concentrate on the lateral. So I could see even, you see, posterior portion here of the breast on the extended lateral. So this is exaggerated lateral CC view. Excellent. Well done, Sumaya.
رباب يعني أنا لما نكون ما أخدت السي سي فيو الأبر منه معناها اللاترال واللور منه الميديال صح؟
Yes. The CC view, it is like that. You will divide it. This portion is lateral and this portion is medial. Excellent. Who want to share us?
This is also both mediolateral oblique.
Both are
First,
mediolateral oblique.
First mediolateral oblique was second extended lateral.
Excellent, Sumaya. Why you said this is extended lateral?
Because when you look for the nipple and divide it into two, they see that more there is not equal. Then there is a lesion in at the medial near to the pectoralis when it is be clear in the second image.
Because here the lesion is so posterior. It is posterior. Okay, it is really posterior. I could see well the lesion, but I could not see its posterior end. But when I go to extended lateral view, pulling the pectoralis, I could see the posterior portion of it. I could not with a lateral view, just a straight lateral view, this posterior, it will be cut. It will not be well involved as it will be seen on MLO. So definitely this is not a lateral view. This is a CC view, but with exaggeration of the lateral aspect. You got it? Is it clear? Lateral extended CC view. You can do it to visualize the posterior portion of the lesions. So, lateral exaggerated CC, done. Any question regarding this view?
دكتور رباب معلش.
We are not using the medial like the lateral one. Why?
في البريفيوس ايمج معلش.
Excellent.
في البريفيوس كيس.
معلش
دكتور رباب سؤال معلش. يعني انا اعرف الاكزاجريتد سي سي من الاكزاجريتد ام ال او. يعني صراحه انا الصوره الثانيه الكيس الاخيره دي كنت فاكراها lateral MLO.
Yeah, that is why I explain. Why I tell you? Because the nipple coming lower down here, and these projections, you see, of the breast, it looks more or less same like the MLO and the pectoralis muscle here. Okay? But if you have done the lateral, why we explained last time why they are selecting mediolateral oblique instead of mediolateral. Why they select the obliquity? Because we said because the breast tissue resting along and sometimes on or over the pectoralis muscle. You can see sometimes breast tissue through the pectoralis muscle. That means you have deep posterior breast tissue. When you do straight lateral, half of this tissue will be cut away. The extreme posterior will be cut. It will not be involved. That is why they are selecting the obliquity. They are selecting the oblique to rest along the axis of the pectoralis to visualize this deep posterior portion. But very unlikely, okay, to do a lateral view to visualize more deep tissue than the oblique view. You got the point?
Okay, clear.
That is why it is not a lateral view. If it is a lateral, you might not even see this lesion or see just a smaller portion of it, anterior portion of it. Because usually, even the pectoralis muscle on the lateral view, you will see it smaller than the pectoralis muscle on the mediolateral oblique view. Agree?
Yeah, agree.
definitely this it will not be. I brought this image to explain this point.
Okay.
This tip to show you this is, it will not be, though if you look generally, the appearance might tell you this is might be a lateral view with obliquity or without obliquity. But because of that reasons, it cannot be. It's supposed to be extended CC. Because with extended CC, you will pull the pectoralis, you will pull the breast to involve the axillary tail. And to involve the pectoralis on the extended lateral view. So we went through the extended lateral view. I think we had taken multiple cases, different examples, presented more or less thorough. Do you agree? Do you have any question regarding the extended lateral view? Next. Still, we have a lot. Try to go quickly. Huh? What about this case?
Both are CCU.
What is the difference between the two? CCU of what, Sumaya? ICU or CCU?
CCU.
I understand you. I'm just joking.
الأكسس بتاعي.
No problem. No. Just confusion. I used to say something like that. Yeah, this is the CC views of right breast. Agree?
No, left breast.
Agree, left breast. This is a CC view of left breast. So you have two images. Why you have two images? Why you have two CC?
Two CC.
Why not a single image?
Communication.
Huh?
Communication.
No, can you read the corners of the image? Nothing is written in this image. You have to make use of anything.
One image before the other, prior and current.
Yes. You have to think about that. One image prior, and that's one is current.
Yeah.
So what does it show? The current compared to the previous.
Focal area of
Hind?
the
Hind is
current.
talking.
أنا سارة عثمان.
Sarah Osman, you're welcome, Sarah. Where are you? We
أنا
miss
ما
you.
أعرف المحاضرة تفاجأت.
Okay.
The current image, there is there is
there is arrow here.
Yeah, anterior glandular tissue. There is a small
arrow. Look for the contour. Look for the contour here, and look for the contour here.
Different from the previous.
Yes, it become full.
Yeah.
So there is some area of distortion at least, or asymmetry, or added density. You can tell anything is accepted. Okay, at least there is something here. There is something new compared to the previous. There is something new. When we have seen something new, we call it what do we call a new opacity compared to the previous?
Developing asymmetry.
Developing asymmetry. So we are dealing with a developing asymmetry. What is the next step? What is the next step if you have seen a developing asymmetry?
In this case?
In this case or general? You have seen a developing asymmetry, we put a rule. This asymmetry, it can be, ممكن تكون just technical and the orientation is different. And this is just a superimposed tissue.
We do spot magnification.
It can be real, or it can be a lot of differentiation.
Magnification?
Spot magnification.
Yeah, spot magnification. Spot magnification, not magnification بس.
Yeah, spot
ليه؟
magnification.
Spot لأنه نحن we need the spot or we need the compression more than the magnification. Okay? So we have to do spot. So, what does it add for you?
It's a real lesion.
I'm showing.
Okay, why you said a real lesion? Why you have two images here? This is the previous and new, or that is the new but different views?
Different views.
A spot of CC and MLO. Spot magnification, compression magnification, CC, compression magnification, MLO or ML. Type. What does it show? Speculated mass with calcification. So that one, it was real. So how does it help us, the compression magnification view? In this case, demonstrate that the developing asymmetry is real
lesion.
Suspicious lesion. So here, take this one. Where is Sarah Al-Mak? She disappeared. I did not hear her voice in a long time. She left?
سارة زي اللي قالت ما قدرت تدخل. I think.
Okay. She has problem? Technical?
Seems so.
Okay. So, who's going to take this one? Quickly, because still we have half of the lecture.
This is mediolateral oblique view of left of right breast. Showing microcalcification at the center of the.
طيب دقيقة، نورس طلعت، دخلت نورس كويس، لأنه شايفة هنا كاتبين they wrote إنه there is technical problem. Go ahead.
Mediolateral oblique of the right breast showing.
Where is the mediolateral oblique?
On the left side.
What is written here?
It's written CC, but for me it is mediolateral oblique.
This is the nipple because it's suboptimal. This is the nipple. Here is the nipple. Even not the whole view is visualized, part of a CC view. It is a part of CC view or suboptimal CC view even. What does it show, the CC view?
Showing micro classification of polymorphic
Why your
appearance.
voice is low?
You hear me?
Raise your voice, please.
Showing a polymorphic microcalcification at the medial part of the left of the right breast.
What is the distribution?
Regional distribution.
Why you said regional?
It is less than.
Did you measure it?
No.
It seems, yes, you can.
Focal?
It is a focal. A grouped. We call it a grouped of microcalcification. Okay?
Okay.
Is it amorphous or polymorphic?
I did not hear her. You said, Anna, I was concentrating on when she said the regional.
Polymorphic, not polymorphic classification. The other one for the same patient, Victoria?
Yes, same patient.
Showing the other, I think it is also CC view. Showing the.
What is the difference between the two views? What is the difference between the two views?
It is compression. It is compression magnification.
Yes. You have to tell. This is a CC view, and the other one is a spot magnification or compression magnification view. The standard CC view demonstrates it is apparent as a group. If we concentrate more, it might be segmental, but because it is not very clear, just I will take this one as a group of, if we have two different type of classification, we label with which one? Worser, the much worse type of classification. This is coarse, heterogeneous, and polymorphic. So I will go for polymorphic. Okay? So this is a group of, how does it help us, the spot magnification view?
دكتورة.
Human distribution of the calcification.
معلش الشبكة تاني دخل. طيب.
If there is underlying mass or no?
In this case, not tell me theory. Yani, we are taking case discussion. And to see the importance of each additional view. We discussed some of the cases regarding the compression and spot compression magnification view. And this is one of these cases. Tell me in this case how this spot magnification help us in the management of this case. At the beginning, does it help or not?
It helps the calcification.
Okay, it helps. Type in which way? How does it help us?
It's showing the microcalcification in segmental distribution. And polymorphic in segmental distribution. There is two area of microcalcification.
Here I cannot say a segmental distribution. Here I suspect, but here, because they concentrate exactly in this area. This area is corresponding to this area. I could not go more anterior to see it. This is a little bit more, I think it is more posterior, probably. Okay, this is a more posterior here. So I could see a group and another group of similar calcification is just seen adjacent to the first larger group. And it characterize the type of calcification. This type of calcification is coarse heterogeneous along with polymorphic type of calcification. Both are suspicious, and this also another. So this is most likely multifocal, or it might be multicentric if we look for the remain of the breast, but at least it is multifocal DCIS. Okay, with or without invasive component, it depends. But at least this is most likely representing the high-grade ductal carcinoma in situ, or at least moderate grade. Okay, the arrow for the another focus, which was not visualized on the standard view, seen only on the spot view. Who will take this? This lady, diagnostic mammography, presented with a palpable abnormality. Any suggestion for the laterality of palpable abnormality? Which side?
Left side.
Excellent. Who said left? Who said left?
Left side, yeah. On the left.
Excellent, excellent.
Inner quadrant.
Inner quadrant.
Inner, type inner on CC. On the MLO?
Lower.
Lower, yeah.
Well done, Sarah. Well done. Lower inner. Tell me what is the abnormality? What is the mammographic abnormality?
Focal asymmetry.
Is it a focal or more than focal?
More than focal.
Yeah, global asymmetry. Only asymmetry or any something else?
I think there is a mass, irregular mass.
I could not see a mass. I can see as global asymmetry. But when I have seen a global asymmetry, I have to look for any associated features. Any association with this global? Can you just
retracted
zoom it in your phone? Can you zoom it? Yeah, it can be not retracted, but not retracted. The nipple.
Microcalcification.
Can you see a microcalcification?
Yeah.
Yeah.
Excellent. Yes. What else? Subtle distortion.
Yes.
Some distortion is there. And microcalcification. So what is next?
Magnification.
Focal spot magnification.
Magnification.
So
compression magnification or spot magnification is here. So demonstrate what and where. Quickly. Still we have a lot.
Branching, microcalcification, segmental distribution.
Linear branching calcification. The segmental distribution.
This is polymorphic. Extensive polymorphic. If you look here, this is what?
Skin thickening.
This is a nipple. This is a nipple. And this it will be the medial breast. And look here, lateral to the nipple, and they complete it here. This is the lateral portion. So this portion of the breast from medial and lateral quadrants are involved. But let us see where exactly these, the medial and lateral, in the upper or in the lower or both. We have to go for the MLO. Now in MLO, this is the nipple.
Central to the lower.
Yes. So medial and lateral, the lower half of the breast, almost the whole lower half of the breast is involved. And here I can see some asymmetries and the distortion now and a lot of issues. So this lady having a palpable abnormality, and she has multi-centric invasive high-grade ductal carcinoma and ductal carcinoma in situ. Invasive and DCIS, both. Okay? You can revise again the standard view. Compare it with a spot. Okay. Next. وين فاطمة بخيت مشت؟
قاعدة.
ها؟ Do you like to take this one? I like it for you because it is a daily case report. A daily case, yes, it is a daily case report. Every day you might have seen this type of cases.
It is there is spot magnification.
أيوة. Yes, you are right.
Cluster of microcalcification.
Excellent, but cluster, they obsolete terminology. They said according to them, طبعا they change. They from time to time they are usually change their terminology and ask us not to mention the old one. Please go to the new one. So according to the latest 5th edition, that one at 2013, expected this year to be the 6th edition, latest version. But according to the latest available one, they changed from cluster to group type of classification. They said don't say cluster, but say grouped classification. Distribution. When it is within 2 centimeters. More than 2 centimeters, you can say regional. If it is not going in segmental distribution, and if it is not going in triangular pointing toward the nipple, say it regional. If it is pointing, you can say segmental. If it is going to the line, say linear. If it's taking the whole breast, say diffuse. Diffuse, but not like the previous case. The previous case will say extensive. We have to differentiate between extensive and diffuse. Okay? When we go to
please again.
To discuss it in more details, but at least now this is a group of classification. But you did not mention to me which spot magnification. Single spot magnification. If it is single spot magnification, we'll say this spot magnification CC or spot magnification MLO.
The one on the left written mediolateral, but the one on the right
craniocaudal.
Craniocaudal.
The right spot craniocaudal, and the left is not mediolateral oblique. It is what?
True mediolateral. True.
Mediolateral. Excellent. It is mediolateral. It's straight mediolateral or true mediolateral. You are right. So what is difference between the two? Yes, same group of classification or cluster of classification as previously saying. This group of classification, okay? I cannot say in which press or where, just what I have seen is a group of classification. This is a distribution. Then I have to tell the morphology of this type of classification. Let us start by craniocaudal. How does it look on craniocaudal?
Spindle shape. Spindle? Or what?
Okay, so we have, when we talk about distribution morphology, we are talking about 4 types of classification: amorphous, polymorphic, coarse heterogeneous, or linear and linear branching. These 4 types.
I think it is polymorphic.
The polymorphic, the previous examples we have seen were the polymorphic. The coarse heterogeneous, the one we have seen before, it was a coarse heterogeneous with polymorphic. But because polymorphic is more suspicious, we label it as polymorphic. We ignore coarse heterogeneous. Here we have the predominantly. Can you tell exactly which particle look like? It is hazy. Do you agree with me? It looks hazy.
Stone.
It looks,
crushed stone.
It looks hazy. Agree? It looks,
yeah.
It looks like a hazy, not very clear, not very sharp. This is what we call it amorphous type. Okay, you cannot tell exactly what is the shape, what is the margin, what is, it is hazy, it is fuzzy. It's what we call it amorphous type of classification. But on the craniocaudal, it is amorphous. How it is the same? Can you characterize it in the medial lateral view? Does it look the same? Or it changed? Have a look at it carefully. Close.
If you're more linear.
Change.
Does it change, Fatma?
Yes.
Maija, does it change? Does it change on the mediolateral view, or it looks the same? As
it changed.
It's excellent. This is important. Since it change in shape or in distribution or both?
Both.
Excellent. Okay. But at least the most important is the change in morphology. This change of morphology is important. Does it become more obvious or less than in the CC?
More obvious.
More obvious. Yeah. And it looks like what? If you see this type, these particles, can you see it here? Looks like what? It arranged like what?
Buck.
Huh?
Buck. Like buck.
No. It went like a line. Yeah?
Yeah.
It become more or like, it become a little bit more sharp and more linear. If you look here dots like, but here more or less linear like. But being changed in shape, okay, by itself, this is indicative of something. And when changing shape, it goes more linear, or if we magnified more magnification, you might see something more. This is what we call it, what? We call it what? What do we call this appearance?
Of calcium.
Yes, excellent. So this is the layering, Fatma. That is the layering of milk of calcium. That is why the milk of calcium in the latest or the coming editions, they change its name to layering calcifications. Okay, layering calcifications. But since it changed itself when in the, this is the effect of gravity, because it is a milk of calcium in microcyst. This is the common why you will see it every day. Go and open the bags and you'll see a lot like this. Okay, and don't be hesitant or confused. Make sure, because there are, yani every day you will see at least 5 to 7 ladies from 10 having fibrocystic changes. And this is the fibrocystic changes, one of the features of fibrocystic changes seen on mammography. Okay, this is the milk of calcium. That is why I've shown to you. Huda.
Yeah. This is a mammogram of the right breast. CT view, showing microcalcification. Group arranged in group. Magnification spot view.
But if you have seen something that associated with calcification, in this case, you have to start with that things. Okay, then we'll go to calcifications. If it is calcification, bare just a calcification, only calcification, then you will go for morphology and distribution. But if it is associated with
architecture distortion,
is it only distortion? It's okay. This is the mass.
Mass, not speculated mass.
This
speculated mass.
Because here, look at it here. This is what? This view. What is the other view?
This is magnification.
Yeah, spot magnification. How does it help us? It shows that this calcification is associated with speculated mass. You see, these all, and this is a pleomorphic type of calcifications. Okay? And you can say more than that. You can say this is linear because there are some linear, even though the linear are fewer than pleomorphic, but because it is more suspicious, you will say this is a linear and linear branching calcification associated with high density. Look at it, how it become more dense than even here. Okay, high density speculated mass. So how does it help us characterize the speculated mass as well as the associated high level or high suspicious type of calcifications? That is our case, it was invasive cancer. Next, Sarah Usman.
ممكن دكتورة رباب بس كيس غير ده شوية كده.
Okay, no problem. Huh?
طيب.
Who is going to take this?
Mediolateral oblique of the mediolateral and craniocaudal view of left breast. One done after the other, after 1 year of the first image. Showing developing asymmetry.
Excellent. Demonstrate developing asymmetry. Excellent. Since it was not seen and now you have seen it, focal asymmetry, this is a developing asymmetry. So what is next?
Spot compression view.
Okay. Okay. So
spot compression view demonstrate unspeculated small mass, a high density mass.
Well done. Yes, you have to compare, ya Jama'a. Okay, look here and look at it here. Now, even denser than the surrounding tissue, because you remove the normal tissue, so you will visualize the speculated mass. This is very small speculated mass, high density mass. What is next to here? So here, what is next?
Ultrasound and biopsy.
Excellent.
No, for biopsy.
Huh?
For biopsy.
Yeah, biopsy, go for ultrasound if you can see it, to make sure that is the same, and take a biopsy because ultrasound is more easier. That was ultrasound. You see the lesion on ultrasound, and it was invasive ductal carcinoma. So what is the lesson from this? If you go back and look to this, yani, very faint and small, tiny area. Huh? What is the lesson?
The benefit
What
of screening.
do you learn from this case?
The importance of screening.
Yes, excellent. Importance of screening. What else? For us as a radiologist or breast imager. So when
perfectly examine the image.
While we are reading the mammography.
Dedicated. We should be dedicated.
Dedicated, and to improve our level of suspicion. Okay, we have to maintain high suspicions to work out any asymmetry, especially developing asymmetry. Okay, so what about this? Here it is more easy because they are pointing for us. There is something here, we are not sure what is that. So seen on MLO and CC view, there is no previous image. So this is a baseline image, and I have seen something here, both not clearly masked. So what we call this? What do we call it?
Asymmetry.
Asymmetry or focal asymmetry? This we call it a focal asymmetry.
Focal asymmetry.
Yes, we call it because we could see asymmetry if I have seen it in a single view. Seen it at the two view, then I will call it as focal asymmetry. What is next?
Spot magnification view.
Spot magnification. This is a spot magnification. How does it help you?
Now it is a mass.
Yes, excellent. Now it is a mass, but it looks oval, circumscribed, sharp, partially obscured mass. So I have to go for
ultrasound.
To characterize by ultrasound, and it was just a simple cyst and downgraded to PIRAT 2. Okay. So teaching points from the above discussed part of the lecture is that the radiologist cannot simply rely on the probability that most asymmetries are summation artifacts. We have seen a lot of asymmetries representing evolving cancer. And under compressions can create pseudo lesion also. We have to put in our minds. Okay, and it might also fail to demonstrate real malignancy in a case of advanced. It might obscure small cancer. Spot compression, with or without magnification, is really helpful for two reasons. Either to differentiate between real and pseudo lesion, true lesion and pseudo lesions, and to delineate the area of interest, give better delineation for the area of the interest. And this we cannot for all of the patients just go for a spot. So we have to select the cases, specific type of cases, and we have to use our common sense. Okay. Can you tell me this case? Which one is first and which one is second? And why? There is something here. It looks like an speculated mass here. Which one is first? Which one is second?
B is the first and A is the second.
A is the first, B is second.
Yes.
A
second.
Okay.
Which one? Who said? Let me ask you. Who said A is the first?
Me. Suhaib.
Raise your hand.
All we do, we tell that A is first.
A is first.
لا B
طيب.
is first. No, I said B.
Sarah said B is first.
And I also B is first.
Fatma said B is first.
Yes.
طيب. Let us start by Fatma and Sarah. Why B is first? On what basis?
No. I changed my mind because I see something rounded, but it's not the same place in A. I thought it is in A. It is a rounded lesion, but it is anterior to this side. You see it in A. So I changed my mind.
Which one is first?
A is first.
A is first. Sarah.
Yes.
B is first.
Why Sarah B is first?
The lymph nodes region in the axilla.
There is reason you have to defend yourself when you say something. All of us as a radiologist, if you have seen it, if you have said anything, we have to defend ourselves.
There is a large lymph node in the axilla seen in the A, not seen in the B.
So they might cover the axilla in one, but they did not cover it well in the other.
There is a speculated lesion more obvious in the B.
So what does it mean?
That means A is the first and B is the second.
So you mean this is, so why you have seen this? Why not to be the reverse? Why not this is a pseudo lesions? Okay, they start by B and then they change, and that pseudo lesion disappear in A.
Maybe.
Okay, so you are not sure. So you are not sure. Who is confident of his answer? Huh? Nihad, where are you? We miss your discussion.
We are done without compression.
Who is talking?
Samia. There is overlap.
Who's talking? Who's Samia? Welcome, Samia. This is the first time you share us.
Yes.
Yes, Samia. Excellent. Well done. Explain for us again.
There is tissue overlap in image A.
So
and the mass is not obvious in the A, After compression in the B, the mass is obvious now.
Excellent, well done. This is the exact explanation. How can I make sure? How can I make sure? Yani, how can I defend myself more, Sami? Why I suspect the second having better compression than the first? Correct, 100%. You are correct. Okay. Let me tell you here. We said it also may fail to demonstrate a real malignancy in dense breast because lesion conspicuity in dense tissue is partly dependent on the extent to which the normal tissue is pushed away from the lesion. And here, there was not enough compression. But when they compress it well, they pushed the tissue away from the lesion, we could visualize. And to compare, to make sure this is better than this one, look for the resolution. First of all, here, a folding. Here, there is no folding. Okay, stretch well. Look for the pectoralis the margin of the pectoralis, how it is sharp here, and look at it here. Look even for the contrast and delineation, differentiation of the breast tissue, how it is very clear in this image compared to that image. And even the skin, the resolution, contrast and spatial resolution, both of which. Here it's much more, look for these vessels, okay? And look for this vessel here, how it is hazy. Look for the contour of the parenchyma, how it is hazy in this image, but more clear. So definitely, this is a better image. This is a more, there is more compression. They pushed away, okay? This is under compression. This is proper compression, especially at the central portions. That is why there was a hidden cancer depicted when they correct the compression. Without even do spot magnification, just they correct the compression for the whole breast. We could push away the normal parenchyma and we could visualize the lesions. Is it clear? So that is the importance of compression and the spot compression view. Let us go for another section. Huh? Straightforward. This is, we call it what? So I have no prior and current study. I have one single study, baseline study. I could see something here and here. So we call it what?
Focal asymmetry.
Huh?
Focal asymmetry.
And it is written here. Focal asymmetry in the lower inner quadrant. So what is next?
Ultrasound.
Okay, before ultrasound.
Spot magnification.
Spot magnifications. So, how does it help us, the spot magnification?
Speculated.
First of all, it persists. It does not fade away. The pseudo lesion or superimposition of parenchyma, it will fade away. But when it persists, that means it's a true lesion and demonstrates the speculation. So we are dealing with a true suspicious lesion. True suspicious lesion. So I will go for then. When I will go for ultrasound, if I did not find something, I might say at this level, I might say there is nothing. But after the spot magnification, no, there is something. I'm sure there is something. even if I could not find it on ultrasound, I will tell myself, no, definitely this patient having a real lesions. I have to solve our problem. You see, this is one of the importance of the spot magnification view or the additional views. So I will go for ultrasound.
Ultrasound.
This is the ultrasound. I could see these lesions. But look for this parenchyma. Look for the parenchyma. This simulate this, simulate this, simulate this. So they have taken biopsy from this. So shall I take a biopsy and send the patient home, and that is it, or come again to look for the to discuss her result? That is it, or I have to do something first? So the teaching point of the second case, pass
Marker.
Which marker?
A skin marker.
Skin marker for what? You see, because I have to make sure first I have taken biopsy from the correct lesions, from the same lesion on mammography. We discussed that issue before. Because this complex or this heterogeneous parenchyma might, and these small lesions, look at it, look at this one, simulate, but because here surrounding by fat, it appears like an asymmetry, but it might be within these portions. So I'm not sure exactly if this corresponding to that one or not. How can I solve this problem? Yes, I want to make sure I have taken biopsy from this. I want to make sure this is corresponding to this area. By shape and size, it looks like it. But I want to make sure before complete everything. Before just taking biopsy, put the clips, and that is it. Before that, how can I make sure? One way, just to make sure.
By location.
Any suggestion? For lesion, there is one view we use it for triangulation and lesion localization. Which view? We said even when we discuss
mediolateral.
So we said
mediolateral.
Straight lateral view. Straight lateral view. Here lateromedial is better because the lesion on the medial aspect, but it is a lateral view. We said for inclusions of a lot of or much breast tissue, the MLO, that's why the MLO is superior and selected not the straight lateral, but is not orthogonal for the CC view, and the lateral view is orthogonal to the CC view. You see, that is why the lateral view is the view used for triangulation and lesion localization. So we will put a needle and we'll do lateral view, and here you can see the needle. It is pointing to the same asymmetry. And this, it was ductal epithelial hyperplasia with 1 millimeter focus of invasive ductal carcinoma. The lesion itself, it was 5 millimeter. And there is 1 millimeter within it is infiltrative ductal carcinoma.
يعني يا دكتورة رباب أنا هوديها التراساوند وبعدين أرجع تاني للماما.
Yes, just to make sure that is the same, we are talking about the same lesion. Before send the patient like the first one.
Okay.
And the result came different discordance. And at the end, we found that there is mammography ultrasound discordance. From the beginning, in these challenging cases and doubtful, from the beginning, we have to make sure we are talking about the same asymmetry on mammography that is corresponding to the ultrasound lesions, and the biopsy taken from the same. So when the result came, it represents these lesions, and because this is highly suspicious, if the result the result came benign, then it will be, we have to put a wire and excise, make an excisional biopsy or excise the lesions for biopsy. We'll go for second case. Can you tell me the difference between these two? Mammogram. And how can it help us? What is the difference? Who is going to win this case?
The difference is in the view. This is as written MLO, and this is lateral, true lateral.
Sarah?
Yes.
You are welcome, huh? You said this is what?
This is true lateral, more.
True lateral view?
هي spot magnification view or compression view.
Spot magnification view from true lateral,
and
this is magnification view
from MLO.
From MLO. What is the difference between the two?
More characterization for the lesion in the true lateral.
So what does it mean? Excellent, Sarah. What does it mean? More characterization or more clarity?
Clarity.
More clarity. Excellent. Well done. On the lateral. What does it indicate? What does it mean? Why it is more clear on the true lateral view? If you could answer this, you will win the case. Now half of the prize for you.
Because the lesion is more lateral.
Excellent.
The lateral side.
Excellent. Because the lesion is laterally located in the outer breast. Excellent.
Yeah.
You won the case. Full prize.
Thank you.
Thank you. You see, we discussed before, when the lesions close to the image receptor, it will be more clear. Here on MLO, a lot of breast tissue included. Okay, and the lesions, it visualized, we could see it, but not as much as clear and more characterization as on the lateral view, because in general magnification views increase the spatial resolution, but being the lesion more adjacent to the receptors, so it will be further characterized. The lesion, so it will be more characterized on the lateral spot magnification view. What we call this type of doing lateral view, we call it what? To localize the lesions. Which technique? What is the name of techniques when we use straight lateral view to localize the lesions?
Mediolateral technique.
Additional view.
It is an additional view, but it has an Any of you do know it? Do you know exactly the name for using lateral view in localizing the, we call it triangulation. Triangulation technique. Okay. Better clarity لأنه الليجن في outer breast as you said. Another case or another mammogram. Who is going to take this case? Noura's left, or she's still here with us? Noura's, are you here? Who is going to take this case?
Yes. For views, it showed speculated mass in the right MLO.
Fatima.
Yeah.
We said if we have seen the opacity in a single view, we will not call it a mass until we could see it in two views.
Okay.
So here at this level, we call it
asymmetry.
Yes. We call as asymmetry.
Okay.
There is asymmetry in
the outer.
In the posterior upper right breast. Right breast. I don't know exactly where. So what is the next? This is the MLO. What is the next?
الكيس ده نفس اللي فات.
ها؟
نفس الكيس اللي فات.
دقيقة يا سمية. دقيقة فاطمة طيب عشان ما تنسى سؤالها. السؤال الكيس اللي فاتت مالا؟
الصورة دي هي الكيس اللي فات. هي نفسه كيس واحد.
ليه كيس واحد؟
نفس الليجون.
ما السبيكيوليشن دي ما كثيرة يا شابة. طيب it is similar type. So what is next step, Fatma?
Since we could not see it in the CC, we will do additional view. Exaggerated extended lateral view.
Exaggerated extended lateral view. طيب ليه اخترت exaggerated lateral view?
Because the lesion is posteriorly in the LO and superior. Superior and superior.
يعني no much superior شايفة؟
Central.
ده posterior nipple line يعني قريب من النص كده. Yes it is posterior لكنه ما فوق مع الابيكس بتاعت الهنا. طيب لو عايز اتاكد you could not defend yourself اكتر من كده. you can defend yourself but اذا عايز اتاكد انا I'm not 100% sure يعني ما زي الكيسز الجبال. كيسز الجبال so extreme posterior و high دي خلاص I will go for the extended lateral. ده probability انه يكون lateral is high. لكن أنا عايز أتأكد إني أمشي lateral ولا احتمال يكون medial. طيب ممكن أعمل view وبعدين
true lateral.
true lateral. طيب ده true lateral. طيب في true lateral إيه صار؟ إيه صار في true lateral؟
ليد
وقعت تحت. Excellent, well done. Excellent. وقعت تحت، بعدين بقى more sharp more delineated ووقع تحت هنا وهنا نزل تحت. So expected to be خلاص يلا. أيوة يلا هنا ده extended lateral view you can see it. شايفين هنا في MLO في MLO at higher level في straight lateral بقى lower، ولما عملنا extended lateral very clear يا هدى في اللاترال. لكن لو جيتي تقنعيني ممكن تقنعيني من هنا من السي فيو، هتقول لي medially I could see the breast لحد نص البريست هنا الميديال aspect لحد البكتوراليس. الposterior breast is completely 100% included في الميديال but not on the lateral. البيشنت شنو النيبل tilted medially laterally. الحتة دي هنا if I divided the breast the lateral aspect is smaller than medial, so most likely this lesion it will be lateral. Okay, and this is one issue, and being just in the upper or posterior probability of being lateral is more than medial, like not as the previous cases we have discussed. So this is lead. This is a triangulation technique and lead, and that is the same lesion ya Sumaya. Okay, but if I said to you this is the same lesion, we are not going, you cannot discuss all these points. Okay, excellent your observation. يعني you are as the prof said عندك شمارات كويسة ممتازة. Are you with us Sumaya?
Yes, okay.
أيوة, you have good observations, but if I tell you if I told you yes it is the same lesion, يعني you will burn the discussion. Okay.
See, lesion as in the lateral from the previous image.
Huh? What did you say?
It is good discussion for the view and technique.
Yeah, if I told you it is the same, I know it is the same lesion, but if I told you it is the same, يعني, we cannot discuss all these points.
Yes, I get it your point.
Yeah.
يا
Okay.
دكتورة رباب.
أيوة.
طيب يعني نحن في حالة الليجن ده نحن نعمل اللاترال أول حاجة، ولا على طول نمشي نعمل اكستندد لاترال؟ عشان لو بقى في الاكستندد لاترال خلاص يعني مور شارب وواضح في الاكستندد لاترال definitely this is يعني ده في اللاترال يعني.
It depend case per case. It depend. Huh?
يعني مثلا في
from here you see I'll tell you something. From here, from this CC, it is clearly it is lateral because I could see
the medial.
all the medial till the half of the breast. I could see the medial portion, but I could not see the lateral portion. For this the region is يعني if I'll go for extended lateral خلاص. But as general rule, you see, I think this case it was my case, and after I have done this, I did the MLO to make this type of triangulations to make sure about high and low and these things, and I don't know exactly.
بس لانه يعني انا ممكن الكلينيكودال ده ممكن يكون اعتبره يعني ما اوبتيمم، ففي الحاله دي انا بشوف حتى لو عملت عدة الكلينيكودال واوبتيمم وما لقيته، يعني ما لقيت انه في ليجون في الكلينيكودال، برضه هكون في الدايلما دي. يعني هل اعمل
No, in this case I will not repeat. In this case I will not repeat the CC view. I will go for the extended lateral view.
extended.
Okay? In this case For me, I'll go for the extended lateral view.
extended lateral. ايوه انا من الاول كنت عايزه اقول كده لما
Yeah, you will go
يعني
for the
كان في
extended
بالي
lateral,
كده،
not because
لكن لما طلعت
of
عملت اللاترال.
MLO. I'll tell you something. In the previous cases we had discussed before, okay, usually the lesion is projecting over the pectoralis, so extreme posterior, or posterior and superior toward the axillary
Yes,
tail, parenchymal
أيوة.
apex. All these locations are pointing toward the upper outer quadrant. Okay, in the previous cases, but here it is just close, يعني near to the mid
البوستيرير للعين. ايوه معاك في دي
line. It might be medial or lateral.
or lateral. ايوه فانا قلت احسن
Here
اعمل
from this
الاكستندد.
or from only MLO, I cannot tell it is a medial or lateral. I have to go for the straight lateral. But just in correlation with the CC, it is obviously it is lateral lesions. Okay. And what about these lesions? Is it lateral or medial? Just from this. And where would you expect to see this lesion on the CC view? On the lateral aspect or on the medial aspect? And why? Based on this is the MLO and this is a 90 degree. Where is the lesion on MLO and on the 90 degree? Or what is the relation between the lesion on MLO and 90 degree? Huh? That is a lesion here.
طلع traced up.
It is. So
شكله ميديال. اي لانه طبعا شكله ميديال. شكله ميديال لانه فوق.
You see? So here, that is the lesion. So regarding that is the lid and this is the muffins. Okay? And here you can review the triangulation techniques. But what we can say is that lesions, usually we are doing this triangulation technique using the straight lateral if you have seen a lesion on MLO, but you could not see it in the CC view. Then we will go for the straight lateral. If you could see it in a straight lateral, that means it is a real lesions. If you have not seen it, it might not be a true lesions. But if you have seen it, that means it is a true lesions, and then we'll make the triangulations. If it move down, expect it to be lateral. If it moves up on the straight lateral move up, expect it to be where in the medial, and accordingly medial M for muffins, rise, wa lateral let sink or falls, L for lateral. Okay, and this here is obviously it goes or it move from the MLO, it moves down, and here found to be on the lateral view. When you draw a line, it's like that. We have to put the nipple aligned at the same levels to make these triangulations. Again, here to make the triangulation, the CC, MLO, and lateral view aligned at the same, with the MLO in the middle between the CC and the lateral view. Usually from the left, start by the lateral, straight lateral, then MLO, then the CC view. And draw a line from the lesions on the lateral to the MLO and complete the pass. You'll find the lesion on the CC view with the same criteria as we described. The lateral, it will sink or it will go down. The medial, it will go up. Okay, this is the muffins. Let us take examples. This is MLO and this is MLO after 1 year. So here what we have, we call it, this is screening mammogram. So this is
asymmetry.
Developing asymmetry.
Developing
developing
asymmetry.
because it was not seen. Now it is developing asymmetry. Seen only, it was not seen on the CC. So I want to make sure, is it real or not? I will go for
Spot magnification field.
no, before spot magnifications. Okay,
True
so
lateral.
I
True
can do
lateral.
lateral.
I can do lateral. Okay, I can do lateral view. It is there. It is present on the lateral view. What is the difference between the MLO and the lateral view?
More conspicuous.
There, it is there.
on the
Being there, that means it is real. There is a true difference. So,
Yes.
where do you expect to find the lesion on the CC view?
In the medial.
Why?
Lateral.
lateral.
Why? Who said
Lateral.
medial? Who said medial?
Lateral.
It raise up in the true lateral.
It raise up. So what is raise up?
Medial.
Medial. So that is medial. Okay. This is, it was localized on the medial breast, and that was invasive cancer, mixed lobular, and you see this area, can you just easy to be overlooked. It was mixed ductal and lobular carcinoma. You see? Can you look at it again? A lot of lesion like this will be overlooked. Dense mammogram, if we could not concentrate well, to say this area it was free, and now there is added density, it will be easy overlooked. Will be easy missed. But here, doing another view still present, that means it is real. Ultrasound guidance biopsy demonstrate invasive ductal carcinoma. So the differing degree of obliquity between the 90 degree lateral and MLO can help us to determine if the lesion is persistent and therefore a real lesion, or appearance change or disappear, and representing summation artifact. Okay, let us go for this. Let us go quickly. Still, we have a lot of cases, case discussion. What do you think about this asymmetry? Is it real lesion or pseudo lesion? What is the difference? This is the same view or different view? What is this view and what is this view? And where
compression, magnification.
Expect to see this opacity on the other view,
Mediolateral oblique view of the right breast.
And this one?
Compression.
This is a true lateral.
This is a true lateral. This is a true lateral, and this is MLO. So what is next? It will be, where do you expect to see this opacity on the CC view? Lateral or medial?
Yeah. The medial part.
Medial.
Excellent, well done. Why?
It's down.
It traces. Here, you see here at the posterior nipple line, but here a little bit higher than the posterior middle line on the straight lateral. So that is the opacity here. How we can find it? Just put the three at the same levels and then draw it we can draw, we'll see it later, okay? But at least here, that is the lesions, okay? On the medial aspect for this is the one.
يعني دكتورة رباب هو لما يظهر في ال MLO.
ايوه.
لأنه أنا ما واقع لي ما قادرة الحتة بتاعت إنه يظهر كيف وإنه أحدده وين في الCC بعد أشوف
I will discuss. أنا ماشي step by step. خلاص. شوية يعني. I did not give it all to you. We are trying just to repeat يعني same cases عشان المسألة شوية تتخمر وتدخل في الدماغ. خلاص. at least إنه قدرنا نثبت معلومات. أول حاجة إنه to raise up to move up to move down. If it is move up, that means muffins. It is medial. If it is move.
بس أنا دي ما فهمها ليه يعني هو move up lateral يكون medial كيف يعني؟
يلا نعم.
يعني هو move up في lateral.
if في straight move, I will explain this. If it move up, that means it is the medially located lesion. If it move down, that means it is a laterally located lesion. We'll discuss this.
Inshallah. Tamam.
Here it came to you. Okay? This is the medial, that is the breast. Divided into medial and lateral. Here you have, this is the medial located lesions. Okay? This is the mediolateral orientation of MLO. And this is orientation of straight lateral. Okay? This is the same lesions. On a straight lateral, its image, it will come like this here. But for the MLO, it is image, because it is oblique, it will come here. Which one is more near to the nipple? MLO.
The MLO
usually we are doing MLO. Okay? We are doing MLO. And the lesion may be here 2 centimeters from the nipple. When we do straight lateral, we found the lesion 5 centimeters from the nipple. Move up so that the lesions located here on the medial aspect. From this, put it. You see here, this is the posterior nipple line. And on the MLO, the lesion is here. Okay? When we repeat the straight, look for this distance. This distance, it is the one, this here. You take it, and when we do the straight, this is the straight, that is the lesions. That is the distance. You see? It moves up. Can you see? From mediolateral, it moves up. Is it clear? On the medial aspect. Let us go.
ثانية يا دكتورة رباب عيدي النقطة دي معلش.
It's okay. This is the lesions. If you have a lesion here on the medial breast. طيب. When you take the MLO, this is the angle, this is the orientation of the MLO. The lesion, it will come, its image, it will come here. This one. It will be image here. Type. The same lesion, when you image it on the straight, its image will come here. Is it clear? That is why, if you measure this distance, for MLO, that is the one. If you measure this distance for straight, it will be the one. That is why the lesion located medially, it will raise up. Okay, let us take an example here.
Okay.
This is, you have, this is MLO and this is ML. So the lesion, where is the lesion? Up or down?
Down.
So where do you expect the lesion to be?
Lateral.
Medial.
Huh?
Lateral.
Lateral, it's sink. A lead is heavy. The lead is heavy.
Yeah.
Remember that the lead for lateral and lead is heavy. It will fall down. So here it fall down. So expect it to be lateral.
Lateral.
Okay? Let us see the lateral. That is the lateral lesions. The lateral lesion is close to the MLO. You will see it here. The same image for it, you will for the lateral, you will see it here. Which one is close to the nipple? On the straight.
Lateral.
On the straight,
lateral.
it will go down close to the nipple. While on the MLO, it will be at higher level. So that is the distance for the lateral one. It will be here higher, but for the, it will be lower here. You got it?
Yes.
Let us take it together. This is the medial and that is the lateral. This is the same lesion here on the medial aspect, but here on the lateral aspect. The image of which of this lesion, when it is medially, it will be more close to the true lateral. It will be where it will be higher. It will be higher on the true lateral.
MLO.
خلاص? But here it will be lower, at lower level. So it will raise if it is medial. But here, its image, it will be here, it will be more higher than on MLO, but it will be more close to the nipple on the straight. So we have to consider something when we said raise, and to make sure we are talking about the same lesion, we have to have a constant distance, which is a distance from the nipple. We have to make sure we are talking about the same lesions, okay? Regarding the depths, is it in the anterior, middle, or posterior depths? Okay? We'll go again. Let us discuss it again to make it a little bit clear. Triangulation. If you have seen lesion on MLO, but you could not see it, or unseen on the CC view, then you will go for a straight lateral view. If you have seen on a straight lateral view, then it is a real lesions, and you can make a triangulation to try to localize the lesion or to place the lesion on the CC view. Okay, to expect exactly where it could be on the CC view. Straight lateral, you can do it, ML or LM. It depends. Oblique and CC views from left to right. Yani if you have done ML or LM, the straight lateral, put it first and put in the middle the MLO, and then put the CC view, but try to make the nipple aligned for the three views. And then draw a line, straight line from the lesion on the straight lateral view to MLO view. Then along the path of this line, you will find the lesions on the CC view having the same depth and the same distance from the nipple. And you will try to localize this lesion on the face of clock positions. Yani when you see medial or lateral, you have to say medial, upper medial, lower, or medial 12 o'clock, medial 1 o'clock, 2 o'clock, 4 o'clock. Yani it depends here if it is on the right, and if it is on the left, medial 10 o'clock. Yani you have to describe it by clock position, and you have to make sure, as I mentioned before, at which depths. We have to talk about the same lesion. We might talk about something here in the third posterior depths, and in the other view in the anterior depths. Definitely this will not be the lesion. And if the lesions, there are other descriptions. Yani retroareolar, okay, central and axillary tail area. This is not by clock. You can just mention it like that. We'll discuss this in details in the coming lectures. Okay, so if we will take this, here you see, this is ML first. And this is, so since the lesions from MLO going down in ML, what do you expect? To find the lesion laterally. So at the same line, you expect to continue with the path. This is here. It is obviously it moves down. So this is lead. Can you see? Here we complete the path, and that is a lesion on the lateral. Is it clear, ya Sarah? Are you with me? Sarah? She left? Where are you, Sarah?
موجودة أنا.
Is it clear the path now?
Yes.
You asked me before about the path.
Yeah.
That is the way.
Yeah.
You see, you will arrange the MLO on the left, the ML, I mean straight lateral on the left, the MLO in the middle, and the CC view on the right. And
yes.
You will draw line from the ML to MLO. And then you will continue the path. So you will find the lesion on the CC view like this. It is lateral because it moves down. Let us see another example.
Okay.
Oh, so this is ML, the lesion, and this is MLO. So the lesion move up. Expected to be
medial.
So the expected to be, let us see, this is the CC. So let us draw the line. Okay, draw the line. We draw the line. So if we complete the path, you can find it.
Yes.
And at steps, here, this is the lesion in the middle, in the posterior aspect of the middle depth. Is the posterior aspect of the middle, in the posterior aspect of the middle depth. We have to have the same depth. Look for measure this distance from the nipple. Measure the same distance from the nipple and measure the same distance from the nipple to make sure you are talking about the same. Is it clear?
Yes.
So that is the conclusion. We talk about compare the lesion in 90 degree lateral to the MLO. If it is raised, is muffins, because muffin rise, and M for median. If it is false, lead is heavy, it will fall. Okay?
Okay.
What about the central locations? Centrally located lesions. What do you expect if the lesion is centrally located? طيب, look here. The lesion retroareolar centrally located, 12 o'clock centrally located. So where exactly? If it is retroareolar, you will sit at the same on straight and the mediolateral view. It doesn't change its locations. If it is at 12 o'clock, okay, you will see it here, you will see it here on the straight, and you will see it here on the MLO. If you measure the distance here and the distance here, it will be the same. So the central located lesion does not change its place between relief on ML relative to MLO. It has the same place. Is it clear?
Yes.
طيب. If the lesions, if you have medial located lesions seen on MLO, but you could not see it on the straight, or lateral located lesion, you have seen it on the MLO, but you could not see it in a straight, most of the time it will be summation artifact, and it will be a pseudo lesions, okay? And that is the straight lateral views and the strangulations. Is it clear?
Okay.
Okay. Another things in triangulation technique. What is this? What we call this? We discuss in the group. Huh? Are you ready to complete the lecture? Still, just we have one remaining view.
كمل الطلبات بس عشان أثناء الأسبوع بيكون هنا ثاني يوم بيكون دوامات ما زي يوم الجمعة.
Just we are going to be quick. This is, you see, if we have seen lesions in CC or MLO view, we can start by by small angle, 15, 30, 35. Just we call this step oblique mammogram. You see, we call it step oblique mammogram, and it's only it is a multiple image of only one projections. If we could not see the lesion on the lateral view, and if you have seen the lesion on MLO, but you could not see it on the lateral view, then you can do step oblique VUD, okay? And start by 15-degree oblique, and then increase the angles. If you could not see that, that means it is an artifact and summation. If then you can see, that means it is real, and then we can work it up out.
دي ما فكرة التومو يا دكتور رباب.
It's more or less the same. We can work it out, sorry. We can work it out. If it is there, then we can work it out. So, step oblique views done. Let us go for another lesion localization, the last session in these lectures. So you have seen asymmetry here on the CC view, not seen on mammography. How you are going to solve this?
straight lateral.
You might not see it because you could not see it on the MLO. Okay. So first of all, we need to know what is this view type. What is this? What is the adjacent view? What do you suspect?
يا دكتور رباب، هو أنا شفته في الكلينيكودال في الميديال أسبكت، ما ممكن أعمل اللاتروميديال.
في حاجة في there is one
أعمل فيديو
يعني generally if we have a lesions seen on MLO, then we'll go for straight lateral triangulation. If you have seen it on the CC view, you have to do the roll view. Did you hear about the roll view?
No.
This is the roll view. That is the roll view. Okay? The roll view is you are going to move the breast. If it disappears, in this case, this area disappeared. When you roll the breast, it disappeared. That means it is superimposition of normal tissue. If it persists, the same theory. If it persists, that means it is a real lesion, then we can work it out. Even we can do spot magnifications. The roll is just to move the superior portion of the breast. If you roll it laterally, we'll call it rolled lateral. If you roll it medially, we'll call because you have seen the lesion in the CC view, you will put the breast in the CC view. And before compression, you will roll the breast. Either you roll it medially, the superior part of the breast. Either you roll it medially or you roll it laterally. We'll see examples. This case, this is a CC view. This is intramammary lymph node. It had been seen on MLO. But there is another here. This is a single view asymmetry adjacently. Seen here, adjacent to this one. So I want to make sure, is it real or it is superimposition of tissue? I roll the breast medially. That means the superior portion of the breast move toward the medial aspect. It is there, it persists. That means it is not gone. It is real lesions. It is real, okay? And but it moves a little bit from its original place. When when the lateral rolled view performed, the lesions significantly move laterally. So it moves with the direction of the rolling the superior breast. That means this lesion is superior and being moved more with the lateral one. That means it is a lateral, that move more lateral but slightly medial. That most likely this lesion is a medial but in the superior breast. So I will search in the medial superior breast on ultrasound, but could not be identified on ultrasound, that lesions, okay? By localization, it has to be in the superior medial breast, and ultrasound doesn't show the lesion, it was too small, and MRI demonstrated in the upper inner quadrant by arrow enhancing lesion, and biopsy revealed, MRI guided biopsy revealed invasive ductal carcinoma. Do you like to continue? No, yani, this is the only roll view remain for us. To take more example, or you get confused?
Or maybe get confused.
Huh?
It was long time.
We'll
Maybe
continue and we can discuss it another time in the group or something. Because the remaining, the lecture, not too much. This is the only role view. I'll tell you something. What is a role view? Role view, okay? If you have seen opacity in the CC view, but you could not see it on MLO, you could not see it on the lateral view. Seen only on the CC view. You have to make sure, is it a true lesion or a pseudo lesion? You need to move the breast, okay? Try to move it. If this lesion disappears, most likely it will be pseudo lesion. If it persists, then I will see how it moves. In which direction it moves. The same as the lateralization. Okay?
But الصوت كان قطع ممكن نعيد شوية.
الصوت قطع؟ Okay. I will say it again. I told you the role view is utilizing further evaluation of a finding seen only on the CC view. And you have seen it only on the CC view. You could not see it on MLO or lateral view. Like, if you have seen only on the CC view, you cannot say this is just a summation artifact since I could not see it in the other two views and just ignore it. No, you have to work it out. You have to make sure, is it real lesion as in the previous example or not? You will do the roll view. You will move the superior portion of the breast, okay? If it disappears, then it can be a pseudo lesion. If it persists, that means it is a real lesion. Then if it is a real lesion, I will try to move it as much as I can toward an area of a fatty breast. So the visualization of lesion, it will be more easier. Because if I will move it in a denser breast or where there is superimposition by fibroglandular parenchyma, it might give me what? Erroneous effect, because I could not visualize it, not because it disappeared, because it is obscured by the overlapping tissue. I tried to move it in an area of fatty tissue. This is another principle. The other principle is the movement itself. I will give you examples. If you move the superior breast toward the lateral or toward the medial, and then the lesion move with the direction of the superior part of the breast, that means the lesion in the superior breast. If it is moved against the direction of the movement of superior part of the breast, that means it is anterior. And then if you have seen it and it is questionable, for the roll view, after you move it, you can do spot compression view as in these examples. Okay? Is it clear? Huh?
Yes.
Okay.
Okay.
Yes.
Okay. Let me explain here in these illustrations. Here you have medially located lesions. You have seen something here, okay? In the CC view. You can see something here in the CC view. You cannot see it on MLO. Then try to move the superior breast moving lateral. It moves lateral. Okay? And then the mass or this opacity move with the movement of the superior breast. That means it is real. It persists having the same shape. Huh? It is seen on the lateral. It moves with the superior breast. That means I'm dealing with a superior located. If it is seen medially, And here it moves, that means in the upper inner quadrant. I'll see it here at the end, it will move from the medial to lateral. This one here, it disappears at the end. This is in between, while moving. Then when I take the image, here it will disappear, I will see it on the lateral. I could push it with the movement of the superior breast. That means that this a real lesion in the superior part of the breast. If the lesions in the inferior part of the breast, in the CC view, I have seen it laterally, and I move the breast toward the lateral. It will not move laterally because it is in the inferior breast, it will be pushed medially. Okay, it will be pushed medially. If at the end I'll see the lesion here, it was lateral, but I have seen it here, medial, against the movement of the breast here. Superior, that means this lesion is within the inferior part of the breast. Okay, another illustrations. Medial rolling, lateral rolling. This is lateral rolling. Lateral rolling, that means I push superior part of the breast toward the lateral. Medial rolling, if the arrow is a reverse. I push the superior part, what? Toward the medial. You got it? Type. Medial rolling, that means the superior part, I push it medially. If I have seen a lesion here laterally, and in the superior portion, and I push medially, then this lesion, it will go toward medial. And this inferior lesion will go lateral. This will go that direction, and this will go this direction. Here you can see it. The inferior lesions will go laterally, and the superior lesion will go medially. Because I push medial, the superior will go with the direction medial, and the inferior will go against lateral. Right. When I came to the lateral rolling, okay. So I have superior breast here on the lateral, same as this one, but I change the direction of pushing. I push laterally. So the lateral one, I'll try to push it where? I'll push it more lateral, because I'm pushing lateral in the lateral direction. And the lesion here is lateral, so it will be pushed more laterally. Okay, and I'm pushing medial, and this lesion is medial, I'll push it more medially. Is it clear?
Okay. Okay.
Okay, or clear, or get confused, or what?
كبير هنعيدها تاني مرة.
هنعيد والله. ده اللي قاعدة. ده اللي قاعدة medial ولاترال ده.
طويلة.
So, rolled views. Movement of the developing one view asymmetry relative to superior breast tissue determines localization of the lesion seen on the CC view. اتفقنا إنه the lesion, or it is a single view asymmetry, seen only on CC view, not seen neither on MLO or straight lateral, seen on CC view. I want to make sure I have seen it, either I will see it central, or I will see it medial, or I see it lateral. I don't know in the superior or inferior breast, because I could not see it on lateral or medial. or the straight lateral. Okay, any lateral view, oblique or not oblique, I'll not see it in the lateral view. I don't know, it is down or up. I'm going to move the superior breast. When I move the superior breast, push the superior breast laterally, if that lesions move in the same direction of my pushing, that means it is superior. If it moves against my direction of movement, that means it is in the lower breast. That is the theory. That is the theory.
واضحة والله واضحة.
If the lesion does not appreciably move with the superior breast, then it is located central. Okay?
Okay. تمام.
Let us just take this 2 examples. Look at this one. This one, there is dense irregular parenchyma here. And in the inferior breast, dense irregular parenchyma. So on the CC view, this will be superimposed.
Yeah.
And it will appear as area of asymmetry. If I use, and I'm not sure where exactly. It might be one up, one down, but it's not clear to me. Just I have seen it in the CC view because both are superimposed, giving me single view asymmetry. When I push medially, this area of irregular parenchyma, it will move where? Medial, but the inferior one, it will move lateral. So I make separation. I separate it. This move medial and this move lateral. When CC view perform, then no more superimposition. It will clear. You got it?
Yes.
No more dense irregular parenchyma seen. It mimics in the CC view, it mimics speculated lesions. But on MLO, not seen. Because on MLO, each is this one high and this is one low. But on the CC view, superimposed. When I move and roll view like this and do the CC view, I make separation between the two. So no more superimposed parenchyma. So this is not a real lesion. So it will disappear. Okay? Again, this is another example. Here I have speculated mass and I have superimposed irregular dense parenchyma. Both together, I have seen asymmetry. I'm not sure. What is that asymmetry? Is it real lesions or it is the pseudo lesions? Same direction. I make medial rolled view. I push the superior breast medially. So the speculated mass, it will move medially. And the dense parenchyma, irregular parenchyma, it will move laterally. Then I separate the speculated mass from the parenchyma, and it will be clearly visualized. So that means that is the real lesions could be now well seen, and I can do in this area compression view to characterize it or to delineate it further. Is it clear?
طب يا دكتورة رباب أنا ما ممكن بس طوالي أعمل السبوت ماجنيفيكيشن فيو من غير الرولينج؟
ما here by this rolling يعني it will give you more, يعني it will help you more. يعني it will the effect it will be better because you remove this added density. The compression, the spot compression is still, if you have a dense breast, it might not give you more details. It can help, but sometimes still you might confuse. But if you make this one and then do the spot with rolling after you push it and do the spot. So definitely it will give you better effect.
Okay.
You use both. Use the rolling effect and use the more focal compression effect. So you remove the super added dense parenchyma, irregular parenchyma, and then a spot compression, more compression. It will give you definitely better result. And if you look here, this is because it is real lesions. This is the irregular parenchyma in the inferior breast because it moves against the direction. And this is a speculated mass move along with that direction. And that is the rolled view done. So in summary, when to use which view? Calcifications, as you know, spot magnification views or mag views. When you go for the asymmetry, where the challenging and the dilemma. You can do spot mag views, you can do straight lateral views. If you have seen it on MLO, you can do rolled view if you have seen it in the CC view. And even the degree of roll view varies significantly from one case to the others. And all you are trying to achieve with straight lateral and roll view to separate the summation of tissue as we described before, to make sure is it a real lesion or a pseudo lesions. And even if it is a real lesion, when you separate it from the superimposed tissue, it will delineate it better. And as you know, in practice, usually after these views, additional views being followed by ultrasound as we have seen, or you can start by ultrasound and then in the workup and then go for the additional views or vice versa. It depends. And the technologist's responsibility is to make the lesion clear in routine mammogram, make it apparent to the reading radiologist, and the radiologist often find the lesions challenging, difficult to be determined, and to characterize it and to make sure is it a real lesions, is it a pseudo lesions. And in these cases, if the technologists know how to isolate, to separate and identify those suspected areas of concern, this definitely will help the radiologist, help the patient, saves the time and anxiety, technical resources, department finance, and finally the mental health. And when a lesion appears only in one view mammogram, we have to ask ourselves several questions before start random taking any additional views. We have to ask ourselves which projection does the lesion show in, and is the lesion real or made up of overlapping parenchyma? Is it a true or a pseudo lesion? What can we do to find that area in other projections? As we said, the breast is unique and the case management different from case to case. And how can we confirm that we have seen the lesion or overlying area clearly in other projections? And thank you for your patience and attention.
شكرا لك والله لمجهودك بجد يعني الله يبارك فيك.
Okay, thank you. Do you have any question? No problem, we can answer this. I don't know this rolling technique. We went faster in this part of because time is late and you have work tomorrow.
ممكن توقف الريكوردينج؟
It's okay,
بس
no problem.
في الرولينج ده.
Okay.